So greetings everyone, and welcome to the 84th session of the online Optom learning series. Let me introduce to you our speaker for today. The speaker for today definitely needs no introduction, but to the people who are attending today, just for our knowledge on the broad work what Professor Mark Bullimore has done. So he is an internationally renowned scientist, speaker, as well as an educator, currently based in Boulder, Colorado. He received his optometry degree and PhD in vision science from the Aston University in England. He then spent most of his career at the Ohio State University and the University of California at Berkeley, and now is an adjunct professor at the University of Houston. He is an associate editor of Ophthalmic and Physiological Optics Journal and a former editor of the Optometry and Vision Science Journal. His expertise are in myopia, contact lenses, low vision, presbyopia, and refractive surgery. So with all these experience in expertise in all these fields, he is also a consultant for a various number of ophthalmic, surgical, and pharmaceutical companies, where he uses his expertise and knowledge to guide people around. And due to all of these expertise and experience, the work has resulted in approval of, amongst many other things, but to name a few, Paragon CRT lenses, Alcon Ilux lenses, and CooperVision's MySight. So his work has been very instrumental, more of revolving around myopia, what I would say. And he's built up his own website, which is already on the slide, is bullers2020.com. And he's been kind enough also to share a link for recommended reading. So please feel free to go onto his website. There are quite a number of articles and webinar series, what he has done in the previous months and days, where he has put up all the recordings. So if you are interested in myopia, I think this is the website you should go along. So welcome, Professor Mark, onto our platform. Thank you so much for giving us your time. It's a very late evening, but you have been kind enough to give us your time. And let me just leave the screen time to you now.
Well, good evening, everybody. Good morning. Happy Sunday. It's very nice to be talking to such an international group. And it is a little after 9 p.m. or 2100 hours here. So if I'm seem a little tired or sleepy, that's why. And this may also have something to do with it. But it's very nice to meet with you. As I said, I'm in Boulder, Colorado, which is in the middle of the country. I live at 7,000 feet or 2,200 meters, if you like metric. And these are some of my friends. One of the dogs you see in the photograph may wander in behind me while I'm talking. So he's just checking in on me. So I do make my living working for companies big and small. Some of the companies on the screen there you will be very familiar with, and many of them have an interest in myopia. So I've helped some of them get to where they are, and also some of them get to where they're going. And this includes spectacles, contact lenses, Atropine. So all of the things I'm talking about today, I know from an academic point of view, but also from helping companies. As I've already posted there, there's a link to part of my website, and there's some really good papers. Certainly the ones that aren't mine are good papers. But if you want a good overview of where we are in myopia control, the paper I published with Catherine Richdale earlier this year is a good place to start. So these are the things I'm going to talk about today. I'm going to very briefly talk about the prevalence of myopia. I'm going to talk about later on the relationship between myopia and disease and visual impairment. I'm going to spend a big part of my presentation talking about myopia treatments, and I'm also going to talk about the risks associated with contact lens wear, particularly in children. So there's a lot to talk about today. So when you hear somebody talk about myopia, they show the statistic. We call this the drinking slide, because if you go to a myopia conference, everybody shows the statistic. And I say, whenever we show this slide, I have to take a drink. So, and this is a worldwide problem. In many respects, the number you see in the Far East there is probably a low estimate, because there are parts of the Far East, Singapore, Taiwan, and parts of China where the prevalence of myopia is above 80%. But this is a worldwide problem. The other thing that you can see from this slide is the increase in the United States, where I've made my home for over 30 years, has increased by about a factor of 2 over the last 30 years, or the 30 years between the 70s and the turn of the century. But what you can also see is this astronomical increase in higher levels of myopia. And that's perhaps not unexpected, because you see there is a very tight relationship between the overall prevalence of myopia and the prevalence of high myopia. And obviously they go together, but it's not linear. But once you get above 60% prevalence in the population, the prevalence of higher levels of myopia start to go up astronomically. Now, very briefly, I could give a whole presentation on environment and genetics and whatever, but it's a common and popular narrative to say that this increase in myopia is associated with screen use. And we've been hearing this for a long time, be it color televisions, computers, and tablets. But there's a problem with this narrative. If you look at the epidemic in the Far East of myopia, that really kicked in 30 years ago, well before the beginning of the century. And that means that those children were developing myopia in the 70s. Now, the personal computer really didn't arrive until the 80s. I wrote my first paper, my first scientific paper, in around about 1984, 85, on a very primitive computer. But the onset of all this myopia in the Far East predated the development of computers. And it was decades before the onset or the introduction of iPhones and tablets and Androids and all those things. So whereas it's a popular narrative, a lot of the myopia we see really preceded that. And those data I showed, of course, showing the increase in the United States, that was myopia that developed again in the mid to late part of the last century. Now, one thing we do know is that there's a much stronger association between outdoor activities and the incidence of myopia. And it really doesn't matter whether you have no myopic parents or 1 or 2 myopic parents. The more time you spend outside as a child, it lowers the probability of you becoming myopic. And of course, that's a really good public health message, because spending time outside and exercising is not only good for our eyes, it's good for our cardiovascular systems, and can also lower the incidence of diabetes. The other thing I want to mention before I move on is that the earlier the onset of myopia, the more myopia you end up with. So this is a really nice study that was published earlier this year on Chinese kids. And what you can see is that the kids that develop myopia, say at the age of 8, they end up being about a -6, whereas those who develop it later end up when they leave school with much less myopia. So myopia prevention is something I think we're going to do a lot more of in the future, but I don't really have time to talk about it today. So let's talk about now myopia control. And I'm going to spend a lot of time here talking about the body of evidence that really contributes to what we know about myopia control. So we live in an evidence-based world, and when it comes to clinical evidence for the things that we do in practice, randomized clinical trials are the gold standard. They're at the top of the pyramid. Now, we could even put above that meta-analyses, which combine, often case, multiple studies and multiple randomized clinical trials to produce a more compelling and more accurate estimate. And of course, one thing we should always avoid when we're making decisions, whether it's about our own personal health, or about our practice is avoiding social media and politicians. Now, a paper that's on the reading list that's just been published, it's not in its final form yet, so it's at the moment it's sitting on the website at about 80 pages. The final manuscript will be closer to 30 pages, but this really talks about a lot of the things that I could, again, spend a lot of time talking about. So when we're evaluating the efficacy of myopia control, there's a number of things we like to see. Ideally, we'd like to see randomized clinical trials of at least 2 years in duration. We'd like to see masking. We don't call it blinding in ophthalmic studies, we call it masking. And ideally, the child and the examining scientist doesn't know what group they've been assigned to. We like to see refractive error measured, and preferably cycloplegic autorefraction. That's the best way to measure myopia in a clinical trial. And more importantly, we like to see measures of axial length. Now, those two things are generally correlated when it comes to progression, certainly when we're dealing with spectacles and soft contact lenses. And we can talk about, as a metric, 0.1 millimeters of axial elongation being equivalent to a quarter diopter. So 1 millimeter is 2.5 diopters. And you'll see in some studies, in most studies, I'll be giving you millimeters and where possible diopters. Now, one thing you won't hear me talk about is percentages. And if you go to or listen to a lot of presentations on myopia control, they'll be giving you percentage, 30%, 50%, whatever. But percentages can be very misleading. And I'll explain why just in a minute. So when it comes to the scientific literature, axial length is incredibly important for a number of reasons. First of all, it's more tightly linked with disease. People don't develop ocular disease and visual impairment associated with myopia because they have thicker, heavier glasses. It's because their eyeballs are stretched. And when you actually do allow both axial length and refractive error to compete in a statistical model, you find that axial length is a much more strong association. The other reason for measuring axial length is that a lot of our treatments influence the optics. So in the case of overnight orthokeratology, we're flattening the cornea. So we can no longer get a valid measure of refractive error unless we wash the kid out of their lenses for several weeks. So we have to rely on axial length. And the same is true to a certain extent for atropine as well, because obviously atropine is a very strong antimuscarinic and it's affecting the accommodative apparatus of the eye. So as I said already, I'm going to avoid talking about percentage treatment effects and talk about absolute treatment effects. And there are a number of reasons for doing that. But most importantly, when you look at children of different ages, be that 8 or 12, if you think about millimeters or diopters, the treatment is relatively constant across ages. It's not if you think about percentages. It's the same when it comes to race. It's the same when it comes to fast progressors and slow progressors. So absolute treatment, preferably in millimeters, but also diopters is the way to go. The other thing, as you saw at the bottom here, is if we keep treating somebody, the absolute treatment effect accrues over time. But when you look at studies who give the percentage treatment, the first year percentage treatment's usually the highest, and then it goes down over time. So that gives you some idea that this can be a problem. Now, in that paper I was just highlighting earlier, the efficacy in myopia control paper, we looked at a number of studies. And one of the things that's quite clear is that when you look at the reduction in axial elongation due to atropine or Ortho-K or spectacle lenses, whatever you're prescribing to slow myopia, you get the biggest treatment effect in the first year, and then in subsequent years, a smaller treatment effect. So again, you're getting an accrual of treatment over subsequent years, but the treatment effect is actually diminished, or it's not as big as the first year. And the other thing you can see from that graph is nothing is above 0.4 millimeters. We really don't have any literature, any papers published in the scientific literature showing that we have more than about 0.4 millimeters of myopia control, or about a diopter or so. But as I'll show you later, a diopter can still be very meaningful in terms of what it means to the patient in terms of future ocular disease and visual impairment. Now, the other problem with talking about percentages is the myopic calculators, and the PHVI does a lot of great work, and the myopic calculator is really good as something at the point of sale to demonstrate to a parent what is likely to become of their child in terms of their refractive error. So if you look at the red line down the bottom here, if you plug in the child's age and their refractive error, you can get a reasonably accurate prediction of what their refractive trajectory is going to be through their school years. Okay, that's really good. I like that. What's not so good is these calculators assume a constant percentage across the duration of treatment. That's not true. Okay, that is false, and there's a danger that we overpromise if we're using these calculators. What we should be saying is, hey, we can slow things by about a diopter, maybe more, but we shouldn't promise things like 50% slowing, because there is no evidence to demonstrate that that is the case. So let me take you through some of the ways in which we could try to slow myopia and give you an indication of what works and what doesn't. So the first thing is spectacle lenses. Let's talk about undeminusing, and let's talk about progressive addition lenses. Now, there have been two randomized clinical trials that I like showing the effects of undercorrection. And you can see here that both found the same thing. The study on the left was conducted in the UK, a study on the right, I think, was in Israel, but they both show that, somewhat surprisingly, if you undercorrect the child, it actually accelerates their myopia progression. Not by much, but by a meaningful amount, and in some cases, a statistical amount. So our children deserve nice, clear vision, and undercorrecting them is a really bad idea in terms of slowing progression. It doesn't work, and probably makes things worse. The same with progressive addition lenses, and a lot of practitioners still use these lenses. But again, here's two randomized clinical trials. The one on the left is from Hong Kong. The one on the right is a 3-year study out of the US on hundreds of children. And what you see is there's a small effect that is clinically irrelevant. In some cases, it's statistically significant, but 0.2 diopters over 3 years, that's clinically irrelevant. Okay. Now, what the COMET study on the right did do is a subgroup analysis. So they had some disappointment in their overall finding. It's like, okay, are there some groups of children that seem to show a bigger slowing of myopia? And lo and behold, when they split their subjects up into different groups, ESO, Ortho, and Esophoria, and looked at the amount of accommodative lag they had at study entry, they found that they got the biggest treatment effect in the subjects that were esophoric and had accommodative lag, or had above average accommodative lag. So for some people, they thought, oh, this is who we should be prescribing PALs to, and it'll work really well. Well, the researchers acknowledged that this was a post hoc subgroup analysis, so they needed to test that hypothesis again in a second study. So they conducted COMET 2, and this time they just recruited subjects who were myopic, but also who had esophoria and an above average or above 0.050 accommodative lag. What did they find? Pretty much the same result as before. 3 years, about a slowing of a quarter diopter, clinically irrelevant. Now, there are some kinds of bifocals that seem to work a little better. So if you can persuade a child to wear an executive bifocal, which is particularly ugly, you may be able to get a better effect. So this is a study out of Canada on Chinese-Canadian children. And what they found is when they randomized kids to single vision, executive bifocals, and executive bifocals with some prism, that both of the bifocal groups showed slower progression. And the same is true when they looked at the axial elongation. Now, some people like to think that the prism adds something here, but when you look at the axial elongation data, most of the benefit seems to be from the bifocal, but quite a nice treatment effect over 3 years, much bigger than with PALs. Now, the most successful things that we can do optically all rely on putting plus into the periphery. And there's three categories that have proven successful over the past decade or so. Now, just to briefly direct you to some important research on animals, we know from a very careful series of studies conducted in a range of different animal models that refractive error is very much vision dependent. And if we put plus lenses in front of the eye doesn't grow as much. We put minus lenses in front of a young animal eye, it grows more. But the things I want to sort of emphasize here is, again, I could talk for an hour on this. When you have conflicting optical signals between the periphery and the central retina, the periphery dominates. Likewise, if you have sort of a dual focus design, and many of our optical modalities are a dual focus design, when you have conflicting signals in the periphery, the more positive signals dominate. So the plus lenses outweigh the relatively minus lens power in the periphery, and you get less axial elongation. And the other thing, and this is covered nicely by my friend Earl Smith in this award lecture paper, which is, I guess, almost 10 years old, but is still really worth reading, is that he points out that the strategies that have a peripheral component are the ones that seem to be most successful. And the last decade of work has really borne that out. So the first strategy we could use is orthokeratology, which flattens the central cornea, which while leaving the peripheral cornea unaffected or maybe slightly steepened. So what you're doing here is you're correcting the central retina, given a clear image, but you've got myopic defocus around the peripheral cornea, which bathes the retina, the peripheral retina in plus. And about 15 years ago, we got the first reports that corneal reshaping lenses could actually slow the progression or slow the axial elongation. And again, remember, you're altering the cornea, so you really have to rely on axial elongation. You'll also notice, if you look at the graphs down here, that most of the treatment effect occurs relatively early in the study. Now, the same researchers then went and did a randomized clinical trial and essentially found the same thing. Over a 2-year period, there was about a 1/4 millimeter slowing of axial elongation in the patients that were randomized to Ortho-K. And you see that in meta-analyses. So this is one of the many meta-analysis papers on Ortho-K. And it doesn't matter what lenses they use, what part of the world, everybody seems to find about the same result, about a 1/4 millimeter slowing over a 2-year period. So that's rigid lenses. Well, what about multi-zone soft contact lenses, which essentially try and do the same thing? Well, I'm going to highlight 3 papers that have been conducted over at least 2 years. The first was out of the Brian Holden Vision Institute, 500 children randomized to 5 different groups. Single vision, 2 lenses that had some defocus in them, and 2 that had extended depth of focus. What did they find? They found that all 4 treatment lenses, whether it's the myopic defocus or the extended depth of focus, slowed myopia by a very similar amount, about 0.15 millimeters over a 2-year period. Now, what about other studies? Well, you've probably heard about the MySight clinical trial. This was a 3-year study conducted around the world. And this, of course, resulted in the FDA, the Food and Drug Administration in the US, approving this lens for myopia control, the first of its kind in the United States. And what the researchers found was about a 0.7 diopter slowing over 3 years, so much more than those PALs, and about a 0.3 millimeter slowing of axial elongation. And what you can also see is that both in the control group and the treatment group, there was a good correlation between the change in axial length and the change in spherical equivalent. So finally, a study that was published this year that was not on a commercially available lens, but rather looked at some presbyopic multifocal lenses that were center distance lenses. So again, almost 300 patients randomized to single vision and 2 different soft bifocals. Same design, but different ad, a 150 and a 250 ad. What did they find? The medium ad lens really didn't work very well at all. It had no clinically meaningful effect. But the higher ad lens, the plus 250 ad, slowed myopia by about a half a diopter over 2 years, and slowed axial elongation by a commensurate amount. So a couple of things here to point out, which I haven't got on the slide. Firstly, again, over half the treatment benefit in the high ad group was in year 1 compared to the years 2 and 3 combined. And also these results aren't quite as compelling as the MiSight lens, which is designed for myopia control. So the final option that we could have would be to put spectacle lenses that have plus in the periphery. And the first study of its kind was again out of the BHVI, and they looked at 3 different kind of test lenses, and all of them were kind of radial progressive addition lenses. So there was the distance correction in the middle, and then the power increased radially towards the periphery. And none of them worked particularly well, but they highlighted in, again, a subgroup analysis that maybe one of the lenses seemed to work well in the younger children with at least one myopic parent. So the lens was actually commercialized, and it's the Zeiss MyoVision lens. And a second study was conducted. And kids here needed to be younger, 6 to 12 years of age, and have at least one myopic parent. Now, what did the researchers find? Nothing. The lens has no effect whatsoever at slowing axial elongation. So something that people still tend to prescribe, but there are better options emerging. One of those better options is out of the Hong Kong Polytechnic, the DIMS lens. And I don't think for some reason I've got a graph of their data, but you've probably seen it before. But over a 2-year period, they found a slowing of myopia of over half a diopter and a slowing of axial elongation of about 0.3 millimeters. Other lenses are being reported, and again, they haven't been published yet, but I mentioned them to you so you hear about them. One is under investigation in the United States, a DOT lens from a company called Sightglass, and their 1-year results seem quite promising. And then the largest optical company on the planet, Axial, is also pursuing this. They've got a lens that, again, has some special peripheral treatment, some lenslets arranged in a concentric pattern. And again, they've reported, but not published yet, some very promising results showing a significant slowing of myopia. So those are the optical options that we have. And obviously, in some parts of the world, we can prescribe Atropine, which is, to date, the most effective pharmaceutical we have. So a study that really got people's attention that was published almost 15 years ago was the Optom study. And this was out of Singapore. And they randomized kids to either put Atropine in one eye for 2 years or to put a placebo. And remember, important to remember, this was a unilateral study. They didn't want the kids to be completely compromised by having 1% Atropine in both eyes, so they just did it in one eye. What did they find? Well, the placebo eyes progressed by about a diopter and a quarter. The treated eyes, the Atropine-treated eyes, by only a quarter or so. So there was about a 0.9 diopter slowing of myopia progression, a big effect over 2 years, the biggest that I showed you on that graph earlier. And the same with axial elongation. Certainly in the first year of the study, there was an almost a shrinking of axial length in the eyes receiving Atropine, a 0.4 millimeter slowing, which again is about as big as we can get. The problem is when the kids were taken off the Atropine, there was a rebound effect. So if you look here, this is the Atropine eyes over the first 2 years, and then this is the year when they stopped taking the Atropine. And those eyes actually progressed almost as much as the untreated eyes had progressed in the previous 2 years. So big problem of rebound with high concentrations Atropine. Now, the researchers, to their credit, went and did a second study, And this time they looked at 3 different concentrations between 0.01 and 0.5. They didn't have a control group this time, okay? What they found is, compared to the comparison eyes in the previous study, is a slowing of myopia of about 0.7 to 0.9 diopters over a 2-year period in all 3 concentrations. But there's a problem, okay? On the left here, you've got the refractive error data, okay? On the right, you've got the axial length data. So if you look at the axial elongation in the control group from the previous study, it's about 0.4 millimeters. All of the treated groups in the second study, regardless of concentration, progressed or elongated by almost as much. In particular, the low concentration atropine, the 0.01, which has really been pushed by a lot of people, particularly in ophthalmology, it had no effect on axial elongation. Now, fortunately, there are a lot of other ongoing studies, and one of the first ones to be published was the LAMP study, which was out of Hong Kong. And what they did here was they randomized kids to either a control or then 3 different concentrations of atropine. So what I'm showing you here is the change in spherical equivalent on the left, and on the right, the change in axial length. And what you can see is a clear dose response function, and the most effective concentration is clearly 0.05%. What you can also see over here on the right is, again, the 0.01% really had no effect on axial elongation. So there's some consistency between these studies. So to summarize, there's a lot of things that we really don't know about atropine in terms of concentration, tapering, and so on. One thing we are starting to see, of course, is some combination therapies. So this 2-year study was recently published where they had some kids wearing orthokeratology and some kids wearing orthokeratology, but also using atropine. And in the kids that completed the 2-year study, there was a difference between the 2 groups. The atropine seemed to have a beneficial effect. But again, you've got to dig a little deeper into the data, because there was really no difference in the higher myopes, okay? In the higher myopes over here on the left, atropine had no additional effect. It was only really in the lower myopes, where perhaps there's not such a big optical change in their cornea, that the atropine perhaps picked up the slack, okay? So watch this space, because combination therapy is going to get a lot of attention in the next 5 years. So here's that drinking slide again, so cheers. So that statistic is all very interesting to scientists, but what does it mean to the parent of a child? The answer is not much. They're interested in their child, and their questions will be about what's going to happen in terms of progression, what are the risks later on, is the treatment safe, and some other things. So we really have to consider the benefits of myopia control combined with the risks. So let's talk firstly about the risks. Now, in terms of vision with these, both with orthokeratology and with these myopia control soft lenses, is good. This is presenting high contrast acuity, or your standard high visual acuity measure, in children wearing the single vision soft lens and the MySight lens. And you can see that both groups have excellent vision. But of course, the thing that we're concerned about in any form of contact lens is, what is the risk of serious infection, primarily microbial keratitis? And this is a very well-studied part of the field. And my favorite paper on the topic is shown on the table on the right here, a study of almost 300 cases of contact lens-related microbial keratitis. And to summarize this graph, or this table, daily wear is clearly the safest. You get 1 to 2 cases per 10,000 years of wear in daily wear soft lenses. If a patient occasionally sleeps in their lenses, the risk increases. And then if they're frequently or regularly sleeping in lenses, the risk increases further. The other thing to remember is not all microbial keratitis leads to vision loss. It's only about 15%, maybe even less than that. But what these data don't show us is anything about children, because all the cases in this table are 16 years or older. And it doesn't tell us about orthokeratology, in part because it's probably too rare to show up in these data. So let's talk about age. And one misconception is that young children are a greater risk. And when you actually look at studies, this is a retrospective study looking at the risk of corneal infiltrates as a function of different ages, you see that the 8 to 12-year-olds, those are the kids that we might be putting into myopia control soft lenses or Ortho-K, the risk seems to be smallish. When you get to teenagers, the incidence of problems increases. And when people become college students, I won't call them adults, students, the risk goes up even further, in part because there's no longer adult supervision. And you see the same things when you look at prospective studies. And again, one of the papers you can read is this review I wrote a few years ago, summarizing studies of children. And again, if you look at these prospective studies that have followed children for many years, hundreds of kids, it's very rare to find cases of microbial keratitis. In fact, in all of these studies, representing almost 3,000 years of wear, there's only one case of MK. What about orthokeratology? Well, the companies that sell these lenses in the US were mandated to do a study, and we were fortunate enough to conduct that for them. And this was a protocol and results approved by the FDA. So retrospective study of about 1,300 patients, half children, half adults. And what we found is that the incidence of microbial keratitis was about 8 per 10,000 years of wear. We had 2 cases. Both of them were in children. Neither resulted in any loss of vision. So in children, we can say that the incidence is 14 per 10,000. So it's higher than daily wear soft lenses. It's getting up towards other overnight modalities. But generally, I would say, particularly for daily disposable soft lenses, it's a very safe modality to use in children. So let me finish by just talking about the benefits very briefly. And Noel Brennan and myself wrote a paper that was published last year, where really when we're talking about myopia control, we're sort of phrasing the issue by saying that we should care about the long-term visual health of our patient and not just correct their refractive error today. And we go on to say in this very short paper that there's really 3 long-term benefits of lowering somebody's myopia. They're visual. The second is if they're going to have refractive surgery later on. And the third and most important is that by controlling myopia, we can reduce the risk of visual impairment associated with higher levels. So let me take you through those very quickly. So we know that a higher myope has poorer uncorrected visual acuity. You learn that the first week of optometry school. But they also have poorer corrected visual acuity, and they have more difficulty performing everyday tasks and report more challenges related to their vision. They have a greater dependence on their refractive correction. And we also know from a couple of important studies that the higher myopes, and indeed the higher hyperopes, take more risks with their contact lenses. Well, what about refractive correction with surgery? I'm talking about LASIK and similar procedures here. Now, our ophthalmology friends have this cliche related to golf that the shorter putt is easier to sink. And what they're saying there, that it's easier to achieve minimal residual refractive error for lower levels of myopia. And that's going to give you better post-operative uncorrected visual acuity and the need for fewer surgical enhancements. And we also know, of course, that less corneal stroma needs to be removed. And if you are unfortunate to have higher myopia, thinner corneas, or both, you're not going to be eligible for these ablative procedures. Also, you find out that the patients have better preoperative and postoperative visual acuity. So this is a study that some colleagues and I did a few years ago. And if you look at the top left panel, we're using natural pupils, standard high contrast chart, but it doesn't matter whether you look at the patients preoperatively or postoperatively, the high myopes see half to one line worse than the lower myopes, and that's best spectacle corrected. Now you look down the bottom right-hand side. Now we've dilated the pupils and we're using a low contrast chart. Again, you can see that deficit preoperatively, but it's even worse postoperatively. Okay, why is that? Well, it's probably, we didn't measure it, because there's greater spherical aberration. When you correct more refractive error with LASIK, you induce more spherical aberration. That leads to poorer visual or optical quality. Now, of course, the big reason why all of us really get excited or interested in myopia control is that we know, again, from optometry school, that myopia carries a greater risk of some eye diseases, but the big baddie is myopic maculopathy, which is growing to alarming proportions. And myopic maculopathy we can classify using these standard photographs now. The top left-hand side is just a regular tessellated fundus that we see in nearly every myope. We don't call that myopic maculopathy. It's only when we get to that diffuse choroidal atrophy that we can see in the middle at the top there that we classify that as myopic maculopathy, because it's then we start to see some loss of vision. And then that can go on to patchy atrophy and Fuchs spots and all sorts of other stuff, and in extreme cases, choroidal neovascularization. Now, one of the things that Noel and I did in that paper that I was talking about is that we gathered together 5 large studies of myopic maculopathy, and this represents over 20,000 patients in studies across 3 different continents. And you can see that there's this exponential pattern here that as you get to higher levels of myopia, you get a dramatic increase in the proportion of patients who have myopic maculopathy. But what we did is we replotted that on a logarithmic scale. So these are the same data, but all I've done is I've plotted it on a log scale. And the thing that we were really quite surprised and intrigued to see is that all 5 studies, regardless of where they were, all have a very similar slope, okay? And of course, what is the slope of that curve? It's 1.67 per diopter. What that means is that every additional diopter of myopia increases the risk of myopic maculopathy by 67%. That's huge. If you turn that on its head, each diopter less reduces the risk by 40%. So in theory, if we can control myopia, if we can slow myopia just by one diopter, later in life, we will have reduced that patient's risk of myopic maculopathy by 40%. That's a huge public health effect. Now, one other thing about myopic maculopathy is, again, when you look at these studies, myopes below 5 diopters contribute about half the cases of myopic maculopathy. All right, why is that? Well, there's more low myopes than there are high myopes. But what I want you to think of course, now is that myopic maculopathy is not a disease of high myopia. It's a disease of myopia. And as my friend Ian Flitcroft likes to say, there's no safe level of myopia. Now, you can do the same exercise, and I just have a few more slides to show you here. You can do the same exercise for other diseases. So here's 5 studies across a couple of continents looking at primary open-angle glaucoma. And again, you can see that most of the lines here are remarkably parallel. They're spaced out because of different diagnostic criteria. But each diopter of myopia increases the prevalence of open-angle glaucoma by 20%. Same for posterior subcapsular cataract, okay? Increased risk by 20% for every diopter. And then finally, perhaps the one you were expecting, retinal detachment. Here we have to talk about incidence because this is an acute condition rather than prevalence. And each diopter increases the risk by 30%. And the line at the top there, which also shows a very similar slope, is lifetime incidence from a study from many years ago back in Switzerland. So that's all very interesting, but some of these diseases I've talked about there are manageable. What about visual impairment? So the final data I'm going to share with you here is a study out of the Netherlands, and they pulled together a number of large epidemiological studies, and in doing so, they had over 15,000 patients in whom they had both refractive error data and visual acuity data. And these patients were largely over the age of 50. So you can, again, look at their table of data, but what I did here is I replotted the data from that paper, looking at the cumulative risk of visual impairment as a function of level of myopia for 5 different age groups. And again, as you would probably expect, visual impairment increases exponentially with age. It also increases exponentially with myopia. So again, with the power of logarithms, I can replot those data. And again, you see something quite remarkable. Okay, these are the Dutch data from that paper just replotted. What you can see is that regardless of the age of the patient, there's a steady increase in the risk of visual impairment, and it seems to be the same increase in risk regardless of the age group. Now, what is the slope of those lines? Well, I've been conservative here. It's actually closer to 30%, but let's call it 25% for now. And each diopter of myopia, each additional diopter of myopia increases the risk of visual impairment by 25%, regardless of age, okay? This visual impairment doesn't occur at a young age, but by the time you're 55, 60 and above, each diopter contributes an additional 25% risk of visual impairment. Again, let's turn that on its head. If we could slow myopia by a diopter, we could ultimately lower the risk of a patient's visual impairment by 20%. That's huge, okay? If that doesn't get you out of bed tomorrow morning, I don't know what will. So in summary, a diopter matters, okay? We can achieve a diopter through a range of things that we have available to us, and controlling the progression really has the potential to do a number of things. It can reduce the risk of myopic maculopathy by 40%, reduce the risk of open-angle glaucoma by 20%, and reduce the risk of visual impairment by 20%. And it also, if you calculate years of visual impairment, it again has a very potential to make a very meaningful difference to an individual patient's life. So I thank you for listening. And if you have questions, we can field them now. And but if you want to ask me something later offline, want to connect with me, then that's my email address. That's my website. Everything's Bullies 2020. Even I'm on Twitter. My Twitter handle is @Bullies 2020. So I'm easy to find.
Yeah. Thank you, Prof, for that very comprehensive talk on myopia, as well as the treatment options which are available, and most importantly the evidence base. That's really the way forward, what we need to look at. You did address to one of that question what you mentioned out in the chat, which was posted earlier on, about the rate of the degree of myopia as well as the level of myopic maculopathy. So any add-ons you want to take on that before we move?
No, I mean, I think since we published that paper, there's been maybe 4 or 5 other papers out of Germany, Russia, showing other data which generally agrees with that. Excuse me. There's also some data out of France on visual impairment, which really shows the same trends as the Dutch study. And hopefully we'll see some other papers out of the Far East and in other populations that will help us there. Somebody asked about the pathogenesis of developing cataract and whether it depends on the degree of myopia or elongation of the eye. That's a great question. I would assume that it has nothing to do with the thickness of the spectacles. And in the myopic eye, there's really very little change that goes on in the anterior segment. Okay, the cornea is pretty constant. If anything, the lens of the myopic eye is actually a little thinner and flatter. but I'm assuming it has something to do with nutrition and axial length and other stuff in the eye, but I really don't know that. So Sundaram, that's a great question, and something we should try and learn a little bit more about. But it's really only posterior subcapsular cataract that we see this association. Now, you will also find an association between nuclear cataract or nuclear opacity and myopia. But there, it's the cataract that's causing the myopia, okay, rather than the myopia causing the cataract, okay, because in a nuclear cataract, there's a change in the density, change in the refractive index that causes this increase in myopia. But we know from studies of axial elongation that axial elongation or axial length is associated also with posterior subcapsular cataract. So, long answer to a great question.
Yeah. What's your take on is there any study on myopia increase in hereditary or congenital myopia? Is there any differences? Any comments on that?
Well, first thing I would say is that when you've got a young kid with a lot of myopia, it's not the same etiology as the juvenile onset myopia. So I can hear snoring, and my dog's asleep on the ground here. So I was thinking, what's that noise? It's my dog snoring. Whenever I speak, he goes to sleep. Students used to do the same thing. Anyway, so a lot of the early onset myopia is different. And the one advice is, and again, I'm quoting Ian Flitcroft here, is if there's more birthday candles on the cake, if there's more myopia in diopters than there are birthday candles on the cake, then you should think about there's some congenital genetic syndrome like Stickler's or something else, okay? And that kid probably should get genetically tested to make sure they haven't got Stickler's, Marfan's, or something else. It's a question that commonly comes up on discussion groups. You know, I've got a 3-year-old with 6 diopters of myopia. Should I put them in Ortho-K or should I put them on Atropine? We don't have data on that. And, you know, I think managing the child's refractive error is the most important thing, but you really can't apply the data I showed you, which is largely on 8 to 10-year-olds. You can't apply that to 4 or 5-year-olds. So, AJ, that's another great question. And if you actually I keep thinking of other answers here. If you look at progression rates before the age of 6, it's actually lower than after the age of 6, okay? Progression in juvenile onset myopia decreases with age, but it's actually a little bit lower in these earlier onset myopes. So another nugget of question.
Okay. The next one is there are some interest in the idea that it is not peripheral refraction in general for the whole spectrum of light, but due to the chromatic focus of wavelength that drives myopia. So any thoughts about this particular aspect, Prof?
Another great question, Kia. So if I'm right, Kia's at Alabama at the moment. Did I get that right? I'm looking at my cheat sheet here. Yes, Kia's at UAB. You have to tell me who you're working with, Kia. So I probably know them, and I'll say some nice things about you. But based on your question, you're probably working with Tom Norton and Tim Gorm. So anyway, but let's answer your question. One of the great mysteries of myopia is we don't fully understand how the peripheral retina interprets focus and defocus of light and tells the eye how to grow. If you could figure that out, you probably win a Nobel Prize, because it's something we really don't know. And if you think, again, going back to your physiological optics and physiology classes, the peripheral retina, the photoreceptors and the ganglion cells are less dense, and it has poorer acuity than the fovea. If you go out 10 degrees, you go from 6.6 to 660 in terms of acuity. So you've got a low visual acuity retina that somehow interprets blur. There's also peripheral astigmatism. Okay, how does that work? And obviously, one of the attractive things that's underlying your question here is, well, maybe it's chromatic aberration, and that's providing a clue. And a lot of people, including people at University of Alabama, Birmingham, people up in Boston, people in Houston, are trying to look at this. And you probably know more about it than I do right now, Kia. So I don't have anything to add. The other thing that I talked about was the benefit of outdoor time compared to being indoors, and how that reduces the incidence of myopia, and it may or may not slow the progression of myopia. So, but again, what is it about outdoors that makes you become less myopic? Is it because the diopters are less? You know, you've got more distance vision. Is it because of the color? Is there more blue light? Is it because your pupil size is smaller? So there's a range of competing hypotheses, again, that would be very important to find out over time. But great question, again, that I don't really know the answer to, but you're probably smart enough to help figure it out yourself. So good luck with your studies.
Thank you.
Oh, you work with Andrew, yes. Okay, and you and Tim debated often. Thanks for punching that in there. Yeah, I taught Andrew Parker, who's your back at OSU, and we're working together on a couple of things right now, which is fun. So, next question. Sorry, I'm rambling.
Yeah, no problem. What's your preference or the best treatment for children who have pathological myopia? How would you as a go about?
Now, pathological myopia, I have to be careful talking about that, because we had some discussions with reviewers on our recent paper about whether we should talk about pathological myopia or myopic maculopathy. You know, pathological myopia is perhaps a little bit separate, and you could say that staphyloma is a hallmark of that, but it's obviously a much more challenging thing to manage, and there's really not much we can do about it optically. It's possible that over time we'll have some better pharmaceuticals, but I don't see patients. I don't treat these kind of things. It's a great question, but Shapnan, I don't have a good answer. And one of the important things I learned very early in being a university lecturer is it's okay to say I don't know.
That's right. Because myopia is something where we really don't know a lot of things, right? And figuring out our way.
I could probably write a top 10 list of unanswered questions in myopia, and you guys are asking most of them this evening. So
okay. So the other one is kind of a case scenario where a 9 diopter mother is having 9 diopter of myopia, very high myopia, who develops CNVM at 50 years of age. Will the children have any risk of any complications?
Great question, because we know that myopia has a strong genetic component. If you have a couple of myopic parents, chances are you're going to be a myopic kid. And we could argue whether that's because of the genes or because of a shared visual environment, but regardless, it doesn't matter. Shit happens. It's gonna happen. Now, there's not a strong correlation between the level of myopia in parents and the level of myopia in children. And you again asked a question that I don't think we've studied, and that is, if you've got a mother who develops, an advanced myopic maculopathy with choroidal neovascularization, is the child at greater risk? I would say intuitively that the risk is going to be associated mainly with the level of myopia. So if I'm a -5, I'm not, but if I were a -5 and my friend were a -5, that we'd have the same level of risk. I don't know that whether our parents developed serious complications, I don't know whether that would affect our risk. Again, because these are studies that are difficult to do, because by the time somebody's developing these complications, I mean, by the time you get to 50, how many of your parents are around? I'm 58. Both my parents are still alive, but studying disease in parents and in children as adults is challenging because they frequently live in different cities. But that's a great question again that we should ask of probably smarter people, but I'm not aware of any studies that have looked at that risk. So good question, Arvind. Are we talking about your mother?
Let's see. We'll wait for that answer on the chat.
Yeah. Go ahead. What's this question?
The next is about the anisometropic amblyopia. In terms of amblyopia, which is associated with the myopia, what's your take on that in terms of myopia control?
Mm-hmm. So, again, this is a question that comes up all the time because, you know, we know that we can slow or manipulate refractive error in myopia. People say, well, what about hyperopia? Could we somehow accelerate axial elongation? And if we have anisometropia, could we accelerate in one eye? And most people in the field would say no, because myopia and hyperopia are different beasts. And, you know, if you got a hyperopic eye, its ability to respond and emmetrobize is probably broken. So trying to manipulate it is probably, you know, like spitting into the rain. It's not a good idea, or it's not going to be a successful outcome. So the interesting thing is with anisomyopia, so when you've got different levels of myopia, we typically don't see amblyopia. And some people have demonstrated that you can reduce the level of anisometropia with orthokeratology. Now, you can reduce it maybe by 10% a year, so you can't eliminate it. So the question is, does that have much clinical relevance? But hyperopia, anisometropic amblyopia, it's a different visual system than the myopic eye, and it might be attractive to try and apply one thing to the other, but probably not going to work. But good question, Sandra.
Okay.
Really good questions here. You only invite your best students to these webinars?
I think after your talk, they have got the basic knowledge, so they are asking you more advanced questions. That's
These are great. These are as good a questions as I get from US trained optometrists with lots of experience and stuff. So good for you guys.
Yeah.
I toast to your health.
Yes. And I think this will help you to, quickly prepare your things unanswered about myopia.
It's interesting because, the same questions come up a lot of the time, but how shall I say? There's always some new ideas and new questions. So you got another question or two before we finish, or you want to?
Yeah, we have a couple of questions which we would take,
Sure.
2 or 3 more. Yeah, if that's fine.
Yeah. Look at this. How do you eliminate the spherical aberration caused by pupil size and contrast postoperative method, which would be best for refractive surgical procedure? Okay. So you picked up on something I said there about visual quality in higher myopes who undergo refractive surgery. And, I think it's very difficult to avoid spherical aberration in higher corrections, okay? You're trying to make the cornea do something it doesn't want to. So, if you got a 6 millimeter ablation zone, and you get a really nice optical quality in that 6 millimeters, you're still going to end up with an optical zone that is less than 6 millimeters because, you know, there's epithelial remodeling and whatever. I do think that some of our newer procedures have the potential to give us better results. So SMILE, which I can never remember what that stands for, but basically you're creating 2 cuts with a femtosecond laser. So you're not creating a flap, and then you create a little hole and pull the little bit of tissue out. And that should give you a structurally more sound cornea. But I haven't seen a lot of data comparing the optical quality in higher levels of myopia with LASIK or PRK or whatever. But, you know, again, a great question. I'm fortunate to only be about a 1.5, 2 diopter myope. So I made my mind up pretty early in my life that refractive surgery was not for me because, you know, I can read in bed. Okay, I can sit at my laptop without my glasses, and that's important to me. So I have these progressive lenses. I actually have multiple pairs of them. These are regular progressives, but because I have a big computer screen, and here's something to work with your patients on, my regular progressives don't work on my computer screen because I'm at arm's length. I can't touch my computer screen where I'm sitting here. Okay, so I need an occupational or a computer progressive where I've got a bigger intermediate zone at the top and just a little bit of reading. So yeah. Sorry, giving you my refractive history here, but good question, Chapman. Hope I answered it reasonably well.
Of course, of course. And let's take some question. I think we did discuss this offline, but if probably you just wanted to comment on this, we got this on the email.
Another former student. Yeah, read the question so I have time to think about it.
Yeah. So the question says that why does myopic defocus, usually undercorrected refractive error, when we do it at the central retina, causes myopic progression? So we already made it clear that undercorrection is definitely a no, right? But yet when we undercorrect at the periphery, where we cause defocus at the periphery, it actually protects myopia, or it does not create myopia progression?
Again, it's one of the unsolved questions. I don't have a good answer for that. It's certainly a paradox that when we undercorrect a patient, that they progress a little bit faster. You would expect, based on animal studies, that it would have some beneficial effect, but the fact that it makes things a little bit worse is somewhat counterintuitive. I'm just thankful that we can develop these optical designs, whether they are contact lenses or spectacle lenses, that we can manipulate the periphery and do something beneficial. But I think we're still very early on in our learning curve when it comes to these things, and we'll know a lot more by the time most of you graduate and have been in practice a few years.
That's right. So the key point here is undercorrection is definitely a no in terms of myopia progression.
Yeah, I mean, basically the kid will get worse quicker and they're going to need new glasses quicker.
Yeah.
And you've already blurred them. So, your kids deserve to see well.
That's right.
So correct them fully. But in some parts of the world, people still believe that has a beneficial effect.
Yeah, I think you did give us a couple of papers, but I think there are quite a few more papers also on undercorrection, and they all talk about.
Those are the best.
The ones, yeah.
Those are the best studies, but but it's one of those things we probably shouldn't be arguing about. We should be spending more time thinking about how best to slow myopia
No matter.
rather
Yes.
than worrying too much about mechanisms.
Yes. And again, one on mechanism as well. This one last question we'll just take if you have any thoughts on the role of hemicrying cells in myopia progression. Again, very pathway related question, if I would say it that way.
Yeah, and again, it's one of the things that we're still learning. How does the retina signal the eye to grow? Because remember, basic anatomy. I mean, the imaging and the electrical signaling happens in the retina. You've then got this vascular layer with all this blood rushing across in the choroid, and then you've got the sclera, which is collagen, which is a dynamic structure behind that really sort of determines the shape of the eye and the size of the eye. And we know that we can do short-term things to the eye, so we could put plus lenses in front of the eye and the choroid will thicken. Okay, we can put minus lenses in front of the eye and get the opposite effect. And, that suggests that the choroid has some important role. In terms of the retina, okay, we've got photoreceptors, we've got ganglion cells, and in between we've got amacrine, horizontal, and what's the other one I'm forgetting about? Bipolar. The important ones. Okay, and then you've got some other things. So you've got photosensitive, intrinsically photosensitive ganglion cells, which we know have a role in terms of circadian rhythms. Do they have some role to play? I don't know. Again, there are smarter people than me asking these questions and trying to figure it out. In terms of amacrine cells, you guys tell me, how many different classes of amacrine cells are there? 20? Okay. So again, is it possible that there's one subgroup of amacrine cells that play a role in eye growth and eye size? I think that's reasonable to assume, but I think we've probably got another 10 or 20 years of work to figure that out. So, as I was saying to our host beforehand, I said, I taught Frank many years ago. I was a postgraduate. He was an optometry student, so that would have been about 35 years ago. So, makes me feel very old. But you can tell that just from my.
I think you should be proud that your students are asking you such great questions.
Well, he's probably sleeping though because it's 5 a.m. in the morning back in England. So I'm pretty sure he didn't get up to listen to me. So he just wanted to tweak me a little bit and give me a hard time. Obviously, ask me some questions I couldn't answer. So good for you, Frank.
Thank you so much, Prof. I think he'll have a look at the recordings and then he'll get back to you and you can have a discussion over the phone.
No, that's thanks. I'll be sure to. So anyway, it's a great set of questions, people. It's been a real joy staying up late on Saturday night and interacting with you. I hope I get to meet some of you in person somewhere down the road. And thanks for inviting me, Fakhruddin.
Thank you so much, Professor Mark, for giving us your time. I know it's a weekend, it's a very late evening, but thank you so much for giving us this time and doing the session for us.
All right. Well, and again, if people have questions, shoot me an email. I may say read this paper, or I don't know. But anyway, it's been nice interacting with you all, and enjoy your Sunday.
Yes. Thank you so much. Thank you so much, Prof.
All right. Thanks.
You too. Have a good sleep and a good rest, and we'll see you around as well. Thank you. And
all right.
Attendees, I'm just going to share some information for the attendees. So the first thing which I want to, just keep in mind that we have a case presentation series lined up at the OOLS platform. So if you have any interesting cases which you want to present, please feel free to submit your abstract and the scientific committee will look into it and we will schedule your presentations. So thank you everyone for attending. We do have session plans over the next weekend. I will see you all again next weekend. Until then, stay safe, take care, and bye-bye.